So TPN hypertonic solution, it has to go through a central line. When to use it, who is it for? We kind of gave some of the examples. You don't have to memorize. Just kind of use your brain on like what makes sense. People that have issues with absorption, nutrition, people who are MPO for a really long time, people who are having issue maintaining their weight, um, some people with the Crohn's disease and stuff, all those um, bowel conditions that lead to them being impaled for a long period of time. People with severe burns, chemo, even those with like pancreatitis, because you got to rest the bowel. So kind of a general idea. Talked about how if you can choose one or the other, you're always gonna try enteral first, preferred to you for you to use the GI tract. If you use it, or if you don't use it, you lose it kind of idea, like with your muscles. I mean, the stomach is a muscle, like that, the whole area there, GI tract, which is why sometimes like immobility can cause a slower GI tract, um, because it is a muscle, and if you're not being active, then it's gonna be slowed down. It's not gonna be as strong. Another reason why elderly have issues with like constipation and stuff. So because you are using a central line, that's another reason why you would rather be using like an NG tube for feeding instead, or like even a J tube, because TPN, like we said, should be through a central line. So it comes all those issues there. CLABSI, talked about bacterial translocation, and you don't have to know the patho really. Just kind of understand that that's something that can happen. You can have an infection from long periods of not being able to get food into the stomach. Probably the main thing to know about it is that flagyl, so metronidazole, can be given for prevention. And then we talked about the TPN content, and a lot of it, um, he listed like a whole bunch of stuff. You don't have to know it all. The main thing I kind of try to write down what was the most important thing. So for your proteins, the most important thing to know is that you want to maintain the positive nitrogen balance. If you have enough protein available through nutrition, then you can help prevent muscle wasting. And the word for that is called cachexia. So if you see it as a possible answer, just know what that means. So that means muscle wasting. So you don't want to get caught on just like purely the terminology. Like you might know you want it for to prevent muscle wasting, but then they use the technical term, so you don't get caught on that. For carbohydrates, we know it's one of your main energy sources. Um, can also be if you have carbs, then your body doesn't have to resort to using protein for energy. So it also helps to prevent the negative nitrogen balance and staying in a positive one. You should know the amount of dextrose in your TPN. Typically, it's about 10%. For the lipids, probably the most important things is just it's every 12 hours can be given as opposed to your TPN, which is every 24. Um, someone's allergic to eggs, they can't receive lipids. The lipids are made with some egg products. Allergies might be have reactions to it. Some other things that might be in the TPN, H2 blocker, so there to prevent like acid reflux and stuff, prevent gastric ulcers. So H2 blockers, the ones that end in Dean. And sometimes, not always, can have insulin. And like I was saying before, is there an alternative? They are allergic to eggs. That is a great question. I honestly don't know the answer to that. I'll look it up while kind of talking about the rest. So with insulin, like I mentioned before, he really likes catching people on regular uh, insulin being like the only one you can use for IV. So he really likes questions where like the answer might be to give insulin through the IV, not but it's only regular. So he'll put like a non-regular insulin, for example, potentially. And even though like the answer is you want to give insulin, you don't want to give like NPH insulin, for example. You don't want to give Lantus insulin IV, for example, regular insulin. So that's where people can get caught. it doesn't always have insulin, so they could do insulin outside of the TPN as well. But it's a possibility. And heparin might also be sometimes in there. Another thing that gets put down in the contents, water, vitamins, minerals, electrolytes. You don't have to know the specifics about each one. I know there's a lot. Um, I'll try to find the answer to that one question. Generally, you want to know what it's is in there. So, like for the things that might sometimes be in there, you should know. You want to know if there's insulin in there. You don't want to double insulin someone, and whatnot. Let's cut about where we left off. You just know it's important to know what's in there. Monitor appropriate lab, appropriate condition. So it looks like if they are allergic to eggs, so a lot of the time it contains egg yolk. There are different lipids that are based on fish oils instead, or they might use different solutions, probably more expensive, different. So that's a good question. I don't think it's gonna come up, but that is a good question. Let me see. So then, for other goals of therapy, um, probably like some of your other goals that you want to include is just kind of maintain, like a short-term goal is to maintain weight. Um, Keep in mind, like, what does it mean? Like the difference between preventing and difference between like an actual goal. So your actual goal would be to have maintenance of weight. Um, Give me a second to adjust this. I understand the difference between like goal and prevention, like what's going to prevent versus um I guess just under here's what I'm trying to say. Oh, uh, I guess like for actual things that make a difference versus things that prevent things that might not. Yeah, I'm actually really struggling with the wording on this. Give me a second. Yeah, like preventing complications. So like there are, yeah, I think like that. I guess this might just be general, but like he likes to catch people on stuff like that, like understand, like look through the wording really well. So like if a question asks you for things that help prevent complications, you're not clicking the stuff that assesses for the complication happening, if that makes sense. Like the things that actually prevent the thing from happening versus the things like a test, like a diagnostic that doesn't actually prevent it, but it just like catches it, you know? Just keep that in mind in general. Just kind of the something that came to my mind. We already talked about positive nitrogen balance, so I'm just gonna write it down. Kind of like weight maintenance. So for example, there was like a question on what your goal, like what your goal of therapy is. Your goal would be maintaining weight. Um, your goal would not be necessarily to um like check their weight. It would be like keep their weight up if that makes sense. Like you're focusing on like the actual things that actually improve or actually prevent versus things that help you kind of spot them. Yeah. Just basically be careful with the wording on some of the questions. It might not be for this topic that I'm thinking about, but I think if you guys are listening to his lectures, there's like he'll mention it. He'll have like one off, like a one off comment about it. He likes to do that. So that's why make sure you pay attention to his lectures because he does like to um, talk through a lot of things you might be able to expect to see. Anything he repeats is really important to keep in mind. Yeah, so Ryan mentioned promote healing. So yeah, that's definitely something else. Want to like that, maintain muscle mass, improve albumin, things like that. Okay. So here, in terms of implementation, we mentioned central line, there's filters and use of specifics on that. You don't really need to worry about. Like I know there's like some like a 1.2 something filter. You don't have to know that deep. But the main thing you really want to think about is how do you want to start it in terms of rate, and then how do you want to wean the same. So what do you guys think? Yeah, same words for both. You want to start slow and wean slow. And why do you think that is? What are you trying to prevent from happening? Yeah, exactly. So Josh mentioned glucose there. So you want to prevent both hypo and hyperglycemia. So if you go too fast, you can cause hyperglycemia. And if you start weaning them too quickly, then you might make them go hypo. Their body's gotten accustomed to getting that TPN at a consistent rate. And if you wean them immediately, you just cut them off, then their body goes into hypo. So you got to be careful with that. So it's also worth noting that when someone's being weaned off, you might give them um, like D10, yeah. Because remember here, if you go up the DPNs, that it can include dextrose D10. So if someone doesn't have a second bag ready to go, you might wean them and then put them on D10 while we're waiting for the second bag to be ready. Okay, so here again, comparing the labels is heparin or insulin included. And keep in mind that this is a high alert medication. So what does that require? When you hear the words high alert, what does that usually entail? Yeah, you're gonna have a second RN check. And high alert medication in this one, only the RN can hang it, the LBN cannot. As per usual, you're gonna check if anything's expired. You want to again see you don't want to understand you want to understand what's going on in the bag. Make sure you have the right thing happening. Like we talked about, one of the main things you're really worried about is preventing an hyper and hypoglycemia. So you are going to want to, yeah, you're going to want to do packet checks every 6 hours so that you can see what's going on with the level. With, where it wasn't showing up. I'm playing with the dimensions right now. Is this one? Okay, there it is. I was trying to look for the option there. Okay, so when it comes to the labs themselves, TPN is essentially kind of like restraints. It gets assessed daily to see what they need. So whatever the patient might need might change on a day-to-day basis. So the order will change, get renewed based on like the lab value. So doctor will take a look and see. Um, they need. Yeah, exactly. So every 24 hours, that will need to be done. In terms of assessment, because we talked about this a lot last week, so I'm kind of just going a little bit faster through it, so we have time to go through hematology. But naturally, you're going to be looking at your labs. Josh mentioned your CMP, so that's going to include like your electrolytes and your albumin and whatnot, UN and creatinine, um, because we're giving them a lot of protein, and when too much protein can stress out the kidneys, so it can overwork the kidney, and that can lead to an acute kidney injury. We'll go over that more. I think like week 5 or 6 is like the renal chapter. Just kind of have the understanding that there is an impact on the kidneys when you have an overflow of protein, which can make sense with some of the things we've learned earlier, like one of the first signs of um, a kidney that is starting to fail or starting to be impaired is the albumin in the urine, and people that are on renal diets should be having low protein diets. So the renal diet includes low protein, so it kind of makes sense from those two things that we've gone over in the past that too much protein can stress out the kidneys. Like a way to think about it. Your white blood cell count, see if you have this central line going on. Remember CLAPC, if there's any like infection starting to happen. And also another thing that we can assess for is ammonia. So the general breakdown of amino acids. So amino acids gets broken down into ammonia. Then your liver will act upon it, turning it into urea nitrogen, and then that will be excreted by the urine. So urea nitrogen, that's part of so when you see a BUN is blood urea nitrogen. So that's the urea nitrogen in your blood because your kidneys weren't able to get rid of it, which is why we use it as a measurement to look at issues with the kidney or issues with hydration or not and whatnot. If you have too much um, ammonia, leads to confusion. We'll talk more about that when we get the liver in the next week. And yeah, that's kind of the general pathway on that one. So just know a lot of proteins being metabolized, ammonia built up. Um, and the BUN is with what? When your liver is not working properly, it cannot build up ammonia build up. Usually your liver will act on the ammonia to turn it into urea nitrogen. So if your liver's not working, you have ammonia built up. Let me confirm if that's true. Yeah, if it doesn't lactose up with ammonia, yes. So if you have a buildup of ammonia, lactulose, I think rifaximin will be given for that. If it doesn't become urea, if it doesn't become urea, then your BUN would be low because it doesn't become. Does that make sense? Let me double check on that though. But it's not as important. It's not really important to know. It's just kind of like a for fun right now. So, some interventions here. You want to refrigerate. I think for this, I kind of just wrote it out because I was like, okay, if we're gonna get through this all, then this part's probably gonna have to be a little bit faster, but we ended up not getting through it anyways. So, but I do think the next section's kind of long. So interventions you want to refrigerate. It helps to prevent infection. You're refrigerating stuff there. Same reason why you want to put food in the refrigerator to keep bacteria from growing. There's that certain temperature that's good. And then how often would you want to take it out before administration? Sure. Let's just go with the number they said in class. Yeah. Yeah, just 1 hour. Just yeah. There's a lot of nuance with all this stuff going over. So, hospital policies make a difference. The actual thing you have on hand makes a difference. But just as long as we're in the class environment, just kind of going off whatever the teacher says in terms of that, even if it might be different at work or whatnot. That's sometimes where like experience can hurt you. For now, we'll just go with what is on the PowerPoint, whatnot. So changing the tubing and TPN, how often do we do it? I think I kind of mentioned it. How much? 24 hours. Your tubing and the TPN every 24 hours. Um, what about the lipids? How often do we change the lipids?
12 hours. Q12?
Oh, exactly. What about the tubing?
Q72 hours? Or
I believe,
same?
I believe actually the tubing is actually every 20 hours, but I'll need to double check.
It's
Oh,
12
that's-
hours.
I thought it was over 72.
Yeah, the lipid goes with the tubing. Just throw it
Uh-huh.
away.
Okay, we'll go with that. I think I'm looking at what I have. I think we had questions on that. Yeah, we'll go with that then. About your central line dressing. So it's kind of, yeah, probably. It makes sense like that. So central line, how often do you want to change the dressing? Yeah. Every 7 days or PRN, whatever makes sense. Yeah, or per policy. But that's not going to be an answer choice in your test. So yeah, you gotta choose. You gotta choose a side. Yeah. So here, think you want to stay with your patient for 15 minutes just to see how they react to what you're doing with the TPN. When administer at a constant rate. Again, we talked about why it's the glucose. Just want to emphasize that. We talked about it a lot. And we talked about this too. What to do if the new TPN is not ready and the current bag is finished. Being D10. I think Brian already mentioned it. D10W. And then lastly, I wanted to talk about taking the blood draw when there's TPN active. There's some guidelines when it comes to it, at least based on what he said. If you guys remember. I think if you had the choice, probably, yeah, probably don't use the same part. He did have like a specific thing on it. I don't know. It's not too important in terms of like getting asked, but yeah, kind of like a single. It was probably like a single slide, like blink it and you miss it kind of thing. If you had to choose, yeah, probably a different one. Oh, from his PowerPoint, he said you could also do stop TPN for about 5 minutes, aspirate, discard a little bit of blood, and then take the blood draw. Not sure how they actually do it in real life, but that's something that stop TPN for about 5 minutes, then aspirate and start about an ml of blood. and then take a blood draw. But you makes sense that you don't really want TPN to interfere with the results, so you stop it for a little bit and then you even like aspirate. So kind of like when you lip the normal saline, you're lipping kind of like that, kind of getting rid of a little bit of it and then taking the blood draw. Or like when you're doing a clean patch for urine, you pee a little bit out and then take the rest. Okay. And lastly, there's the documentation. So what do you think? What do you guys think is important? We talked about blood sugar so much. I'm just gonna write it down automatically. What else think you guys think makes sense? Yep, eyes and up. Pretty much, yeah. Document on your central line, and whatnot. I was tolerated. Yeah, per what else is good? Alongside the eyes and nose for like fluid balance. Yeah, if you flush the line. Yeah. Vitals like I'd say like vital signs labs. Those are all like look through like keep monitor of that. Yeah, exactly. Daily weights. So daily weights. Honestly, I don't see very many people that actually take daily weights if I'm being honest, but in theory it is a uh something they emphasize here a lot. Like for a lot of the lectures they emphasize daily weights for the eyes and nose. Um and be careful with your so basically kind of like the same thing with that we learned in the blood, or that he goes over the blood more than two in a day, more than five in a week is a for concern, something to be concerned of. And it also kind of goes with the fact that we're trying to maintain their weight also. So looking for like FPO, we're looking for how we're maintaining their actual weight. Also just like assessment on what they look like. You know, does it look like they are muscle wasting, whatnot? Yeah, we got through okay, so we got through the last little bit of it pretty okay, like half an hour or so. Any questions on TPN or anyone who wasn't here last time on anything else here? I think I might give you guys another table. I think we're good on. If I can, I'm on my laptop, so a little bit harder than other thing to work with. There we go. Another table just kind of has a bunch of stuff there. Of course, a lot of this stuff can be extra, like a little overachiever kind of thing, but kind of just all in one place, it might help for some stuff. I think a lot of this has to do with it might just be general. I think it's a little stuff on blood sugar, stuff on respiratory, stuff on CLABSI. If I have a PIC line, thermal phlebitis, some of the random interventions you might do. Good. Oh, any questions on anything related to central line, blood, or TPN? Right. I'm gonna give you guys the PDF and then move on to hematology. This is the now with all the stuff on it. I think your next lecture is what on like leadership and delegation, priority and stuff. That one's a little bit more relaxed, but the questions, what gets people to like actual like lecture content's pretty easy. So I think Kaylin and I are gonna kind of do like a combined session. The outline would just be like, here's the most important stuff from each, and then a bunch of questions because that's really what's gonna help for that. I think in class you guys will go over a bunch of questions and scenarios as well. So hopefully all that helps. Brooks's questions on all that stuff gets a little kind of fun, a little funky. Okay. That one. Okay, so now hematology, a lot of it was leukemia and lymphoma. And then what else? Different types of leukemia, multiple myeloma. So for those that went through 222, leukemia was actually a section there. I kind of just summarized it here. Um, and we'll go over and if we have people, so because I know not everyone here started in at the beginning. Some people joined in for the LBN, so they didn't get the full like lecture for leukemia in OBPEDS. But in general, leukemia is cancer of blood forming tissues, bone marrow and lymphatic system, have uncontrolled production of immature white blood cells in the bone marrow. The white blood cells, even though there's a bunch of them, they're not actually very effective in fighting infection. So typically, like they come in because they have infection that's not resolving. They find out through a bunch of tests that they have leukemia. And something to keep in mind is that due to having so much white blood cells, it starts to overcrowd. And if you guys remember from oncology, those cancer cells have a lack of contact inhibition, meaning normally cells, when they're a certain proximity from each other, they basically stop reproducing. Essentially, like the contact inhibition, meaning if they are close enough to make contact, they stop, they inhibit their reproduction. But the cancer cells don't have that. So the cancer cells, they could be bumping right next to each other. They don't care. They'll keep going, but the other cells do stop reproducing. So this overcrowding leads to your red blood cells and your platelets being decreased because this is all happening in the bone marrow. And your bone marrow is going to be your primary site for production of your red blood cells, platelets, and white blood cells. So what is that called when your red blood cells, your platelets, and your white blood cell counts are decreased? Yeah, when all of them are decreased, that would be the pancytopenia. Pancytopenia, essentially, like Carissa said, it consists of a combination of anemia. Anemia would be low H&H, low red blood cells. Combination of that with low platelets, which is thrombocytopenia, and then a combination of that with the white blood cells, which would be leukocytopenia, or if it's specifically once they hit a certain low level of neutrophils, that's when they become neutropenic. But when all of them are happening at once, that's called pancytopenia. Pan, like Pangea, which was like all the continents. If you guys remember from like third grade history or world or whatever it's called. Cyto for cell and penia for lack of. Yep. That's going to be your key thing here is pancytopenia with your leukemia. So it is broken down between acute or chronic. Chronic meaning it's longer lasting, it's built up slowly, more progressive. So a lot of people with chronic, they don't find out until later, a lot later on. Especially because it's slow forming and has the potential to be asymptomatic uh until it starts actually like actively causing problems. Meanwhile, acute, just like what is kind of in the name, it's in a short span, it's kind of all at once. You're gonna have a lot of symptoms, so it gets discovered quickly. So leukemia, because this is happening all not just in your bone marrow, but also your lymphatic system. Your lymphatic system is essentially going all around your body. Um, Eventually, at some point, these cells are bound to infiltrate other areas, metastasize and whatnot. But it also has an impact on the liver and the spleen. So, in this case, the liver and the spleen have an impact on production of blood through different methods. So your spleen, a lot of the time it causes hepatomegaly and splenomegaly. Those are sites that they help. So like production of a lot of your like red blood cells, platelets, white blood cells involve a lot of different systems. So we know with kidneys can release erythropoietin, which stimulates the bone marrow to make RBCs. Your spleen, but also your spleen has a big impact on all of that. It kind of controls, it usually could break down, cause destruction of your unused like red blood cells and platelets and whatnot. It has a big control over it. Um, and then your liver, I can't remember the exact pathway behind it, but it has an impact. So basically, both of those sites compensate. You're eventually going to have enlarged liver and enlarged spleen. And all of this essentially leads to having potentially increased liver function tests. Um, you can have even worsening of your pancytopenia because, again, like I said, the spleen has a large impact on management of and control and maintenance of red blood cell count, white blood cell count, and platelets. So it kind of all comes together, and that's why I don't think they went into too much detail why these two happen, but that's kind of the general basic idea. Any questions so far? I know that's a lot of content to digest at once, but yeah, that's kind of how that goes. Yeah. So then back to kind of like the idea behind the cancer cells. The cancer cells kind of do their own thing. They eventually try to create their own blood supply. They deprive other cells of nutrition, which is why people with cancer they lose a lot of weight quickly because all their nutrition is going towards the cancer cells. They're feeding their cancer essentially, causing a lot of issues. So hypermetabolism, meaning um, the body is essentially acting um, having that muscle wasting, weight loss, fatigue, because leukemia cells are depriving other cells of their nutrition, and then that can lead to, because like we mentioned, the lymphatic system kind of goes around the whole body. Those cells can infiltrate into the meninges, so that is that little um, kind of like pathway in between the skull and the brain. And in there we have cerebral spinal fluid, um, and whatnot. It controls the cranial pressure, but it also has other things in there, such as like it has proteins and glucose in there. So the leukemia cells can infiltrate the meninges, try to acquire more nutrients, and then that's when you have an infiltration there that can lead to kind of what I wrote here, like increased intracranial pressure, which can lead to headaches. If you remember nuchal rigidity, that was one of the key signs. It's basically like a stiff neck, um, that is like a major sign of meningitis. You can have irritability and you can have seizures. So, if you have the leukemia that metastasizes essentially to the brain or to the meninges, you can have that increased intracranial pressure. Lumbar puncture can be done to assess the cerebral spinal fluid. Maybe there's meningitis happening. Something else that might be present in leukemia is this purple rash due to cells infiltrating the skin. But I think the main thing to really focus on, this is a lot of patho. The main thing to really focus on is the fact that you might have this as a finding, the hepatomegaly, splenomegaly, and that you have pancytopenia, which I guess I didn't. Those are probably like your major things. If you can remember pancytopenia, that can really help with all the manifestations that we are going to go over now. So what do you guys remember for manifestations of your leukemia?
Bone pain, weight loss,
Yeah,
fever, fatigue.
on stuff. But you can imagine that if you have cancer of the bone marrow, that your bones are going to hurt. Imagine that if you have cancer of the bone marrow, your bones are going to hurt. Some general symptoms: nausea, vomiting, constant appetite, fatigue for sure. What else? What else makes sense with pancytopenia?
Bruising.
Bruising, yes. So when you don't have platelets, you have issues with platelets, so you're gonna have bruising. Fatigue can come from the anemia part of it. Yeah, so you can have some changes to your body system. Yeah, getting sick a lot, so immunosuppression. Even though you have a ton of white blood cell counts, they're not really useful. Yeah, yeah, you can have the issues with respiratory change, have increased respiratory rate. So we talked about fatigue. Let's talk about I guess with the comes to maybe we can break it down into like anemia, thrombocytopenia part of it. Have anemia has fatigue. If you're having
Color,
anemia, what are some other symptoms that might come with it?
color skin, um,
Yeah,
coolness, like cold, clammy
yeah,
skin,
exactly.
weight loss.
That can happen too. Kind of, or I think we no, we didn't manage to write it. Power, activity intolerance. Yeah. What about compensation? Oh, actually, someone already mentioned. Ryan already mentioned it. Good. So your body compensates. So if your body's not getting enough oxygen because anemia, you have less red blood cells, less RBCs going around. That means your RBCs, what do? They move oxygen around. You don't have oxygen, your body's lacking energy. It's harder to make ATP. So yes, it compensates through tachycardia and tachypnea.
What about increased BP?
Increase what?
No, it's decreased, right?
Yeah, it would be decreased BP.
Decrease.
So it also that kind of also makes sense for why you would have these two happening. When you think about like other things that cause decreased BP, it ends up with these compensatory factors. Like I mentioned, I don't know if I mentioned it to you guys or I mentioned it to the 222 class, but your blood pressure is not the best measurement of. I'm sure Mr. Robbins said it too, but it's not the best measurement for your perfusion just because your body's always compensating. Yeah, he mentioned it. Yeah. Body's always compensating whenever you think about blood pressure. A lot of the time, think about how is that going to affect your respiration? How's that going to affect your heart rate? Yeah, yeah. And then also like decrease cap refills. Hmm. And we already talked about some of the other things like splenomegaly and hepatomegaly. So this is for the anemia. For bruising, we can call that part of thrombocytopenia. Makes sense. Bruising, bleeding.
What about PKA?
Yeah, PTK pretty much kind of goes with the bruising. It's like bruising, there's PTA.
Okay, so it's not different. It's not okay. Well, I guess it makes sense because they're both
Yeah,
purple.
the purple stuff. Ecchymosis, yeah, pretty much all that stuff. Bleeding. So specifically, like something that gets mentioned here, would we say easily bruising? Yeah. Like they don't have to be like actively bruising, but they can. They're more likely to bruise very easily. So what would you want to avoid if someone has a low platelet count that someone might take on a regular? And we want to avoid aspirin and NSAID. They're gonna make the problem worse in terms of that. Might lead them to have some GI bleeds, whatnot. Immunosuppression kind of just goes along with the fact that there is leukocytopenia. So they can get immunosuppression, higher risk of infection, probably higher severity of infection too. And like a last thing that might be there is like there's endless enlarged lymph nodes. I guess that kind of goes with potentially is when we get sick, sometimes the lymph nodes can get enlarged. Not to be confused with like lumps. This isn't like lumps in the lymph nodes. This is referring to the lymph nodes being swollen. What would be your definitive diagnosis for, yeah, yeah, pretty much biopsies are going to be your standard for kind of stuff. What other diagnostics can you do? Just to assess for symptoms and assess like general assessments. CBC, yeah. What will you see in your CBC? I don't worry about that. So yes, you can do a lumbar puncture as well. High white blood cell count, yeah. You can have either high or low. It'd be abnormal in some way. But yeah, neutrophils, yeah, exactly. So you might have a low neutrophils, but what might be high? What could be high? That's a white blood cell. You guys remember it from 212? There was like a question about this. You guys remember what the shift to the left? Not the absolute neutrophils, but it is related to the neutrophil. Kind of. I think the blasts they use that they call that for the improper white blood cell. Yes, the bands. Yes. For the bands. So the shift to the left. So they call this bandemia. So this is your your high bands can be one of your search criteria, but I'm not sure how many hospitals actually. I think the hospital I'm precepting at does a lot of search criteria, but I think now a lot of them are using like was it the SOFA scale? Yeah, those are the immature neutrophils. So they are essentially like a sick. If you have a high amount of immature neutrophils, the bands, it's kind of like you can. It's kind of like showing that they're preparing to go to war. Like like it's like the infection is so bad that we're enlisting the child soldiers in there. Like that kind of concept. Graphs. Oh, I remember it. Well, it's gonna get worse when I give you guys the way I remember the leukemia. Oh, they are. We already told them about that? Okay. Yeah, that's kind of what I do remember. What else can we see in the CDC? We can see the decrease at the lumbar puncture. Oh, your clotting factors. And there's like one diagnostic for a very specific one. If you guys remember, chromosome analysis. Remember which one is the one that has like a special one? Philadelphia, yeah. Philadelphia. That's related to CML. And then you might also get like some x-rays because if you have bone pain, they might just see um if having like bone fractures and stuff. Okay. Any questions so far on all this? Because this was like a pretty condensed overview of leukemia. I think if I had to go back down here, the pancytopenia, if you can remember pancytopenia, that's going to help a lot. I remember the idea that these are immature white blood cells, blasts. Um, they don't fight, they're not effective in fighting infection, can cause hepatomegaly, spleen, and then some general cancer stuff, muscle wasting, weight loss. And the only other special thing maybe to remember is that it can affect the brain, the meninges. I don't think that's emphasized in this class. And then what does it mean to have pancytopenia? You can break it down into like anemia, thrombocytopenia, leukocytopenia. Some of the diagnostics, your biopsies are always going to be your definitive diagnosis for it. And this is cancer of the bone marrow, so it makes sense. Bone marrow biopsy. Okay. So, what are your major complications that you guys can think about when someone has pancytopenia and very especially cancer, leading to ineffective white blood cell? Yeah, infection, sepsis. You're at a higher risk for all this happening. There's even the possibility of like auto contamination. So remember, we have in our body, we have bacteria that can be good for us. Body has a natural flora. But if your body is immunosuppressed, that's when those opportunistic conditions come out. So sometimes it's your own body that gets you. The overgrowth, your flora lead to like infection. Of course, you're gonna monitor for stuff relating to infection, fever. If they have a wound, maybe there's purulent drainage into the retroperineum. Sure, yeah. Like the hemorrhaging can happen, yeah. So a complication that can occur is hemorrhaging. There's some other like specific. We talked that one a lot. I don't know if he emphasized this too hard, but um, hypercalcemia can happen with leukemia. From the oncology in 220, that's like one of the complications alongside like with the spinal cord compression. What else? Superior vena cava syndrome. Hypercalcemia is a possibility for this one. So with um, hypercalcemia, you can have some of the, what do they call them? That the is that six sign, plastic sign, and the trousseau sign. Oh, that's hypocalcemia. Sorry, I don't think he emphasizes it too hard, but it's a possibility. In which case, we just want to flush it out, flush with a lot of fluid. So, person probably on IV fluid, like a bunch of IV fluids. Yeah, bisphosphonates. Bind to it. I think that's just review from 220. I don't think it's too important for this, but yeah. And then your general management, I think important to know your medication. So what's your like main medication for this condition? Yeah, it's your methotrexate, which does a lot. It actually does a ton. Like chemo med, um, it can help with autoimmune diseases. I think this is one of the meds they can give to induce an abortion as well. Does a lot of things. Yeah. So he splits it up into like phases. I don't recall you having to know it into that deep detail. Let me read it through again. Um, if I recall, you guys, yeah, there's like specific phases. Yes, you want to take folic acid when you take this med. Probably like an important thing to actually know. I believe there's pneumonitis, risk of pneumonitis, something that can happen. Yeah, yeah, he had like a induction, consolidation, maintenance, but I don't recall that being too emphasized. But I'll write it down. Jim decided he wanted to change it up. Probably not, but maybe he did. So induction essentially just going into remission. You want to kill the cells into remission, which is where you basically are asymptomatic. Consolidation, that's kind of like, okay, we are asymptomatic now, we're in remission, we're going to ensure that everything is dead to be put into total remission. So they might do the induction with like really aggressive. And maintenance is you might be put on like a maintenance dose just to prevent any cells from growing. I think this could be just for general, but I think they do that for, and you don't have to know that. And obviously this is gonna cause immunosuppression. Uh, what are your side effects? I already kind of talked about. Yeah, kind of like it's immunosuppressant, so it's gonna actually lead to a lot of the same exact symptoms that your cancer's doing, but at least you don't have cancer. So that's kind of yeah, it's gonna lead you to a lot of the same things your cancer is causing, but it's killing the cancer, so you're coming out on top in the end. He did want to, I think I feel like he emphasized in our class this one, so inflammation of the lung tissue. Some things you might have is like dry cough, fever, something he said that platelets return to the normal to slow it. A lot of stuff um on it, but I'm trying to see if I can find just like the most important stuff. What else is? Yeah, pretty much. It pretty much causes all the same stuff, so I'll probably put pancreatitis. Does does a lot. The side effects are also kind of ironic. And then otherwise, like the standard stuff you can expect from chemo, nausea, vomiting, diarrhea, hair loss, stomatitis. Um, much it on that. There's some other specific stuff like chemotherapy. You should do chemotherapy prior to transplant, like a bone marrow stem cell transplant. There's nothing else to this during treatment. Do you guys remember what the exact value is for the neutropenic? Well, do you guys remember the exact value for when someone is when neutrophil count is considered neutropenic? Not sure. I'm sure it depends on your hospital, but I think the exact number what I've looked up is like cells and using the specific unit under 500 cells per millimeters cubed. And what do neutropenic precautions consist of? Yeah, so yeah, the neutropenic diet. Yeah, pretty much no fresh food. That's kind of what that is, though. Private room, yes. So, limit visitors, crowds, close the door and whatnot. Something that might be important to know is there should be no live vaccinations for 2 years after transplant. And the ones that are considered life from the top of my head, MMR, varicella, I think it might be smallpox as well. Yes, flowers. No flowers, no pets. Yoki, any questions so far on anything? I know we're kind of blazing through it right now. So out of all the stuff that's new that we talked about, we already talked about kind of splitting between the three things. That's what's going to make it the easiest. Biopsy is always going to be your definitive. This kind of already goes with what we've talked about in the past. Or complications. Naturally, when you have a white blood cell count, or you have a cancer that directly affects your white blood cells, you can think about infection and sepsis. Some other ones. What are the signs and symptoms of hypercalcemia? Sure, that's a good one. Yeah, so with hypercalcemia, you will see things such as nausea, vomiting, constipation, abdominal pain, muscle weakness, maybe some confusion, so like altered level of consciousness. Arrhythmias, that's a big one with that. Probably your main thing here is your arrhythmias. So with hypercalcemia or hypermagnesium or hyperphosphatemia, arrhythmias are one of your big things that can happen. Let's say the main ones here are probably the last three here. Your main thumbs that will come up. Tetany, like the word that tetany refers to is more for hypocalcemia. So for hypocalcemia, you'll have tetany and the two signs, like the Javastic sign and the Trousseau sign. But for this one, it's just a lot of it goes for a lot of it's more related to the arrhythmias and whatnot. Yeah. Yep. So more muscle weakness, while hypo will be probably more of the tetany, spasms and whatnot. So here is just kind of the difference between lymphocytic and myelogenous. So we have the four different types of, or the ones that we go over, the four types of leukemias that we go over. Like, what's the difference between the lymphocytic one? What's the difference between the myelogenous? I don't believe the specific patho is very important for the test. It's more on your interventions and whatnot, like what to do and like what to expect. But I think this picture is really good for kind of getting a general understanding. But again, it's not a huge thing to know about because you're not a doctor, so you're not the one diagnosing, you're the one intervening. But here, you can see that their blood stem cell will kind of become a myeloid cell or a lymphoid cell. Your lymphoid cell breaks down into specifically different types of white blood cells. The B lymphocyte, T lymphocyte, which are used for your immunity and as well as your NK cell. So in general, here, as you can see, lymphoid leukemias affect the B and T cell lymphocytes only and the natural killer. So in this case, like we talked before, you can have overcrowding leading to the overcrowding of the white blood cell count, leading to the red blood cells and the platelets being decreased because it's so overcrowded. So in that scenario, your pancytopenia is indirect. So having cancer of the lymphoid here, you see has no direct impact on your red blood cell count and platelets. It's the overcrowding that causes you to have pancytopenia. So relatively speaking, the pancytopenia is not as bad. But here you see in the myeloid end, the myeloid stem cells become red blood cells. It becomes platelets, and then some of the granulocytes, which are some of your white blood cells that you'll see in like a CBC with diff, especially your neutrophil. So as you can see from the left-hand side, if you have cancer of this type of cell, it directly affects all three of these. So in this one, your pancytopenia is direct, while here it's indirect. Why your myeloids, your myelo leukemias are worse, have a worse prognosis than your lymphoid. That makes sense? But again, you don't really need to know that. But I think it helps to remember, but you don't really need to know that specific. Okay. So now we can talk about acute lymphocytic leukemia, ALL. What's this most common in? Children. Yeah, so all children get cancer. Awesome. That's how I remember it, is all children get cancer. And then what are some men that sounds so sad. Okay, I think it's the most curable. I believe it's the most curable. For out of it, yeah, the prognosis isn't too bad. Yeah, they'll be fine. Um, yeah. So some of the manifestations, again, this would be a lot of repetitive stuff, so I'll just write down all the stuff and kind of talk about it. So again, pancytopenia. Again, this is gonna be a lot of the same stuff, but it's gonna help hopefully like kind of keep hammering it in. So if you guys are studying from this, you'll see the exact same stuff over and over and over again. But it'll keep kind of coming back and whatnot. So a lot of the same words we've been seeing here. So kind of all the same stuff. The one thing for this one is the treatment. The treatment for this one can include chemo, it can include radiation, it can include the stem cell. Yeah. So one of the unique things about ALL is that this is one of the only ones that actually receive radiation. So typically, for cancers, radiation is like if it's or if you catch cancer in the early stages, you can get away with just radiation, maybe like a excision, some sort of surgery. But a lot of the cancers that are more aggressive. You're going to need to have chemo as well. This is one of the only ones, I think, out of all the ones, at least based off just the PowerPoint and the slides, this is the only one where you'll even consider the radiation because the other ones are a bit more aggressive and whatnot. So the way I think of it is, all children get cancer, but they get all the treatment. All They'll be fine. Relatively speaking, they'll be fine. I can't say one way or the other whether the specific treatment range was relevant. I can't remember if I'm being honest. So like that one, like low if they're low risk and they're age 1 through 9 and their white blood cell count is this, or if they're high risk if they're this age and between this white blood cell. Don't remember if that comes up, but I think this is what I remember the most. So if I'm being specific, I'll put the highest risk are those younger than 1. So usually those that are between 1 and 9.
I think it's the WBCs are greater than 50,000.
Yeah, it's based on that.
And then
Yeah.
low risk is 1 to 9, less than 50,000. So
Yeah. Yeah, exactly. Which makes sense because if we have cancer of the white blood cells, then we can think about having a higher number, meaning your cancer is worse. So that makes sense that your white blood cell count is higher when you're higher risk. Kind of just goes together. I'll include it, but I don't recall if it's on. I'm gonna get you guys to the nitty-gritty of important stuff. I know there's a lot of information, sometimes superfluous. I'll include it here, but again, I don't recall if it's tested to um, knowing this in particular. But it kind of makes sense. You're low risk if you're with, sorry, but yeah, you're low risk if you're within the normal range here. And also if your white blood cell count is not ridiculously over elevated. I mean, this is pretty ridiculously over like, elevated, but based on the number. And you're higher risk if you are outside of this range. So you see that below 1 and above 9 is outside of the common range. And then if your white blood cell count is super crazy. All right. Next up would be the acute myelogenous lymphoma. So with this one, it's most common in who?
Greater than 65.
I believe that's true. I kind of just think about it's more common in adults.
Or common in men
Yeah,
also.
especially men. Over 65, especially, and usually men more likely. What about the severity? Kind of already talked about lymphoid versus myelogenous. So what do you guys think?
And survival's like less than 5
Yeah, it's bad. So this one's
years.
severe. Yeah, it's bad.
Yeah.
Yeah, so this one's very severe. Prognosis is very poor. And that makes sense. We talked about here that on the patho side, the myeloid is directly causing pancytopenia. So you're gonna have a worse prognosis. This is acute of even. So it's all happening at a short like a short, fast progressing period, and it's affecting things directly. So it's gonna be way worse. Your manifestations, again, just think about severe. It's really bad. Severe cytopenia, you're going to have it really bad. Your treatments, it's just going to be your chemo, stem cell, and you're probably going to be on chemo long term. You probably have like a PICC line or tunnel or maybe a port, the port one from a cat. Okay. And there's chronic lymphocytic leukemia. I kind of just wrote it down because not too much. You don't have to hard memorize every risk factor for the stuff, I don't believe. Don't have to hard memorize um, a lot of the random traits. I think your focus is probably on the first two, the ALL and maybe the AML. Just understand the differences. More common in children, more common in older adults, more treatable, while AML is more severe, very severe. Um, so your CLL is genetic, more common in older, like 50 plus. Your typical manifestations, again, pancytopenia, you'll see it every time. You will have probably more instances of splenomegaly, treating it with chemo and bone marrow transplant. If there are risk factors, this one's like what chemicals, herbicides, insecticides, Agent Orange. Again, it's chronic, so progression is slow. And because it's a lymphocytic one, it's not going to be as poor of a prognosis, because it's not directly affecting cells. Meanwhile, there's chronic myelogenous leukemia, again, more common in 50 plus. So as you can see, ALL is really the only one that's common in children. Talked about this already, which is a defining feature is the Philadelphia chromosome. Similar manifestations as all. Um, the management for this one, there's one specific thing. For this one's the tyrosine kinase inhibitor. I just really remember the word Gleevec. But this is not genetic. It's like a acquired. It's like a mutation. Um, and of course, this is also going to be low onset chronic. That the met that exposes the cell to be killed. No, I believe actually is it? Let me see them. Gleevec, what's the exact name? No, this isn't metinib. I think you're thinking of Rituxan. Rituxan. Aylin's whispering in my ear saying Rituxan and Raditz. I think she made a Dragon Ball reference. I don't know if you guys got it, but your brain hurts. There's a lot of stuff in here. Hmm? Yeah. Kalen's going crazy on Crash Bandicoot right now. Yeah. Yeah, so we got Gleevec, chemotherapy, bone marrow transplant. Any questions on anything leukemia? I think sure. I think for like yeah, general management, yeah, Rituxan. I think I just on my to-do list. So I guess I'll go back up to the general management. I missed it. So there's Rituxan. So this one's there to enable the immune system to kill the cancer cells. So this is like Raditz. Well, it's more like Goku sacrificing himself so they could kill Raditz. And I don't know if any of you even understand what I was talking about. That's what Kaylin said she used to remember it. kind of what that is. So then I'll ask you guys a question. If somebody has um leukemia, so they have pancytopenia and whatnot, should they take antibiotics, antivirals, antifungals, um, and whatnot, like beyond all this other stuff? Do you guys think that would immunosuppress them even more, or what are you guys thinking? Yeah, I agree with that. What else do you guys think about in regards to that question? In regards to the use of antibiotics, antivirals, antifungals, while someone is has leukemia. So if this person has issues with infections already, yeah, yeah. If they have an infection, you kind of have to just bite the bullet and give them antibiotics and antivirals and antifungals because a lot of the cancer patients, um, has anyone had a cancer patient in clinical or in work or whatever? Hmm. Yeah. So you'll find that they'll be on a lot of medications that technically they quote unquote like on a healthier person they might not want to be on those medications because of how they affect the liver and the kidneys or whatever, but then they're still on them just because risk versus reward or risk versus like benefit. So even though like yeah, they're gonna immunosuppress them even more, but if they have an infection, it's either it's like, oh, we give you this and we mess up your kidney some more, or you have like worse kidney function, but you're alive versus you're dead. Because yeah, exactly. Did you die? Literally. Like genuinely, yeah. Like it's like, okay, we give you something that's probably not the best for some of you like the way your organs are gonna handle it, the way your body's gonna handle it, but it keeps you alive as opposed to just letting you die from the infection. Does that make sense? Yeah, exactly. Yeah, exactly. So it's like, okay, we mess up the kidney some more, but at least you're alive. Versus, like if I can take care of the kidneys and the liver however much I want, but if the patient's dead, then it doesn't really matter. Maybe for some maybe for like an organ transfusion or something. But um, you guys kind of get the logic behind that. They'll have to take one for the team for overall, aliveness of the person. Okay. So you'll be assessing them really heavily on all the all the things to do with infection, fevers, drainage, coughing, um, how like it could be a lot, whatever infection they have. They have UTI, so like all the UTI specific stuff, all the respiratory specific stuff, even like cellulitis or something. Those are like the three most common things that lead to sepsis is your respiratory, your GU and GI infections, and your skin infections. Those are all like your three most common sepsis leading infections. But yes, you will likely like immunosuppress them more, but it's worth not being dead. Okay. Any other questions on leukemia? And then we'll move on to lymphoma real quick, and then multiple myeloma. Y yes. So immunizations are recommended. Just be really careful with the live vaccination ones. So same thing. I think I mentioned. Yeah. So especially with your transplant, is no live vaccinations, but you can have other vaccinations as long as it's not the MMR, varicella, smallpox. Those are like the most common live vaccination. Yeah. So I think I'd probably put that in general. Um, Random. Rand says, I feel like I heard of read no live vaccination for. Um, I could see that being a thing just because the person getting the live vaccine is getting a weakened version that um of that thing. I think the 2 years is specifically for the stem cell transplant. Like if someone's just living with leukemia for a little bit, I think that a little bit different. Yeah. So that would be for with that post transplant. I think this one's just I wrote this one just for general case. Yeah. So the issue with the live vaccinations is that the idea is that it's a weakened version of the real virus, like a literal weakened. And basically it's the virus, but we like shot their legs, like we like shot their legs off. And so it's like a zombie crawling at you, which for most people like you have no issue, but for the person that's immunosuppressed, that zombie's getting them. You know. Right. So I think something people get confused about a lot is like what is the difference between leukemia and lymphoma? Um, there's like a key thing between them. What can you guys think about? Like the main difference between them? They're both involving the lymphatic system. Yeah, a lot of good answers here. Kind of, yeah, that's kind of on the right track. Yeah, the lymphoma is gonna be um leukemia is a lot of bone marrow and blood, like the blood, a lot of stuff happening in the blood, while your lymphoma is pretty much kind of defined by tumors, like actual hard masses versus a bunch of cancerous cells existing in the blood. There's more like tumors in the lymph system. So is there going to be, you can have here enlarged leukemia, like we mentioned, you can have enlarged lymph nodes, but that doesn't mean nodes for tumor. Because a tumor and the tumor and the lymph node would be like a lymphoma. That's a hard mass, firm hard mass in the lymph system. Versus leukemia can just have enlarged lymph nodes. Kind of like when some people when they get sick, they can have enlarged lymph nodes. So that's something that can get assessed on like a MD or an MP assessment. They might try to assess for lymph node enlargement. And then lymphomas committed very much to the lymphocytes, lymph nodes and spleen and stuff. Not just like the nitty gritty on all that stuff there. Yes, pretty much exactly that, Josh. Okay, so then there's Hodgkin's versus non-Hodgkin's lymphoma. What are some of the causes for it? Kind of has a high correlation with toxins can be one, like carcinogens can be well, a lot of it. Viruses, yes. Oh, there's two white tattoos. I think one of them's Michelle, but one of them's Michelle, I think. Am I wrong? Who's participant? No, Michelle. No, is that? No, that's not Michelle. Who's the second actor? Michelle? Yeah, anyways, causes, potential causes. So the toxins, carcinogens. Probably like the main thing is like viruses can cause it. So Hodgkin's lymphoma is heavily associated with like viruses, specifically the Epstein-Barr um virus as well as HIV. That's not what happens. Barr virus, HIV. So what is it? The virus Epstein-Barr is one of the viruses that causes mono, I believe. Mono. That's what they call that the kissing virus or the kissing disease. It causes a few other things as well, but that's like some of the potential causes. So this like, has a heavy connection to viruses, so infections, viruses, immunosuppression. So this Hodgkin's lymphoma is kind of believed to be possibly triggered by like the immune system having a reaction of some kind. So your manifestation, there's like a presence of some sort of cell, if you guys remember. Yeah, there's some nice. The Reed Sternberg cells. Someone, yeah, exactly. Overproduction of sweats. Yeah, exactly. So you can have night sweats, but let's it's always gonna have this, but let's kind of break it down into A versus B symptoms. So A is A for asymptomatic, and there's B for symptomatic. So your B symptoms. So like your asymptomatic symptoms includes like the having this. So as your condition worsens, you'll have more of column B alongside your column A. But you can have just column A, for example. You can have large, painless masses of unexplained weight loss. Yes. So that kind of goes with the symptomatic thing here. Yeah, more of a you mentioned night sweat, so I'll write it down as well. What else? There's like there's like two more, but like one that I guess I'll yeah, pain ingesting with alcohol, that's something that can be kind of put down into asymptomatic, kind of weird, that kind of related to the symptoms. Yeah, there's like different staging to it. I don't recall it really coming up. Needing to know the staging really hard. I think just really know your symptomatic symptoms. Well, include fever, For staging, there's a picture I like to use. Picture helps me a lot. So essentially, what does it mean to be the A symptoms is like no B symptom. These are your main B symptoms and the different stages when you're symptomatic. You can see here there's an enlarged lymph node here. Um, stage two has two. Stage three will have some both above and below like the diaphragm line. Yeah, it kind of depends on yeah. And then stage four, it will start affecting most. Again, I don't think it really was heavily emphasized as much, like telling them apart or whatever. I think the main thing is just kind of understanding when it is symptomatic, and maybe you might have a question like knowing that the Reed Sternberg cells exist. And I think again, your focus is really a lot on the intervention. That's what you're there for. So this one's very treatable. So this is a very treatable type of cancer. So um, what do you guys think we can do with this? Cancer? Yeah, exactly. So kind of like I mentioned, a lot of the more treatable cancers you can hit just with radiation and surgery and be okay. Chemotherapy is when it gets a little bit more crazy. So you might have external radiation for early, maybe for stages one and two, and then your chemotherapy and radiation, maybe internal radiation. This is more used for stage three and four. You need to be more aggressive. Because remember, your radiation's localized. So if it's only existing, oh, okay, iPad 2 is Nydia. If you only have it localized here in this tiny little area, if you see my mouse here, you don't really need to go full systemic with the chemo. While here, it's all over the place. I mean, before it starts spreading around. And yeah, I don't know if you guys had any issues kind of between lymphoma and leukemia and like their patho or like and whatnot. I don't know if that was the thing you guys had issues understanding or not. I'm just kind of curious if you guys did, if some of you did. It looked like it. Okay. That's good. That's kind of why I included like this line here about like what separates them and whatnot. Um, and that line can get blurred. I watched um I watched a lecture from like an MD going over this, and there's like I guess more current um idea between leukemia and lymphoma is that they're actually they can be very married, like very together. So sometimes leukemia can cause lymphoma. Like for example, if some of the leukemic cells infiltrate a lymph node and then kind of creates a base there, you can have leukemia-induced lymphoma. And then likewise, you can have that lymphoma mass break off and then start affecting you systemically. So you have a lymphoma-induced leukemia. So it's kind of interesting. But you don't need to know any of that at all, even for the NCLEX, because that's like doctor stuff. But I found it really interesting. And I think at the beginning I found them to be a little confusing. So if you ever have like the same kind of things where like you find things confusing, I also recommend looking up videos. That's tends to be really helpful. And non-Hodgkin's lymphoma, there's a billion different types. Um, but you don't need to know any of that at all, genuinely. The main thing you should kind of know is maybe some of the causes. It has a lot of like genetic implications here. More likely family history has an impact. So if you have family, a sibling, they're more likely to get it. Um, Here, I think it also kind of just talks about immunosuppression as well as immunodeficiency viruses. but it's not as specific as the Hodgkin's lymphoma, or yeah, Hodgkin's lymphoma, which kind of tied to some specific viruses causing this this issue. Kind of, I like to think of Hodgkin's lymphoma like you had an infection and then one of your cells goes crazy. It has PTSD and it goes crazy, goes off the wall and starts doing its own thing. Your non-Hodgkin's lymphoma has a much worse prognosis. You're gonna need more interventions with it. Although it kind of depends. There's a lot of different types, but it can be very aggressive. So the way I like to think about it for manifestations, um, is that you can have red itchy patches. I like to think of non-Hodgkin. So the word non, I like to say there's no order, no good skin. So you have patches. It spreads, I guess no order is for them. Like no, you don't have good skin, no good skin. You have, um, it typically spreads through the system, um, through lymphatic system in a less orderly fashion to Hodgkin's. I think of this as no order. All the no words. There is no Reed Sternberg cells. We got another word that we can use no for. You can have hypercalcemia, and another one where you can have hypercalcemia. The other one that we said can have hypercalcemia um, was the leukemia. So I think of this one as like no bones allowed because a lot of the hypercalcemia comes from bone breakdown. So the hypercalcemia in this case is because your lymphoma breaks off and then infiltrates bone tissue. So just like in your leukemia, you can have cells infiltrate bone and then cause bone pain and all this other stuff. And so in this case, it's hypercalcemia due to um, cell infiltration leading to breakdown of the bones and releasing calcium. So I say no bones allowed or no bone. So that's kind of how I remember. It's all the no's. There's no order. It kind of spreads out more chaotic. It's more chaotic. You have red itchy patches. You doesn't allow you to have good skin. No Reed Sternberg. You're not allowed to have um strong bones. So you have all that calcium broken off the bones and into the blood. It's hypercalcemia. That's kind of how I think of it. But again, your focus is also going to be on your management. So being able to tell Hodgkins versus non-Hodgkins apart probably be important. So this is how you might be able to do that. Maybe if you have a select all that apply, treat them like true or false questions. So again, your management is going to be a lot of the same stuff. So just to prevent us from just repeating each other for the millionth time, kind of like glucose radiation and caught early, early, and then um, chemo and probably internal radiation for late stage. You have to be more aggressive. And then here you can also do the Rituxan for the same reason as the other one, and then some stem cell. Well, a lot of your oncology can kind of go down to the localized radiation and surgery caught early, chemo and internal radiation late stage, and then some of the different cancers have specific medications that go along with them. Um, and your medication is always going to be for whatever the origin is. So even if you have stage 4 cancer metastasized to like whatever different part of your body, you're still treating that with whatever medication goes for the original um cancer, because that's infiltrating everywhere. And lastly, we have multiple myeloma. So how would you guys define this one? You winning? I remember this level. Oh, was that the end? Oh, you get all the boxes? Oh, you got all the boxes? Oh shit. Sorry. Oh. Cancer of the plasma cells. Yeah, it's like a cancer of the plasma, leads to abnormal buildup. Um, what do those plasma cells do? So, and specifically, these plasma cells leads to the formation of something. Sure. Clotting factors. What are those in particular? What are clotting factors or what type of major, yeah, they're proteins. Exactly. So what happens when you have a ton of proteins building up? Exactly. It's hard on the liver. So that's how you can connect both of them. So a lot of your issues with your multiple myeloma and can include, of course, your pancytopenia, because again, we have cancer, but also you want to think about how it affects the kidneys, because the kidneys is probably like a really big thing with this one. It's a really big thing with this one. And it makes sense if we can connect the idea that proteins are hard on the kidneys. That's good. That's good that we're already thinking on that level. Let me just catch up on the type for a bit. Um, you guys remember the name of that protein in particular that it makes? Yeah, the M protein. What does the M stand for? No idea. M protein. We'll go more about. We already talked about. Oh yeah, and Nidhi also mentioned the thicker blood. So yes, that's also a thing. It kind of makes sense though. You have a bunch of proteins, blood. Yeah, I believe it's useless. I believe it has no purpose. Kind of just like your cancer cell. Maybe, yeah. It's basically like your cancer cell like spitting out like a random coagulation of stuff. Like your normal plasma cells make proteins, and your cancer cell is um a dysfunctional cell. So when it makes protein, it ends up not making something functional. All it really does is cause issues with that. Um, we'll talk. I guess we'll just kind of go like this now. But how would you manage all this protein happening? Think about some of the stuff that helps with kidney function. If your kidneys are struggling to get, yes, exactly. So in general, you want to think of kidneys, you want to think of getting fluids going. You want to make sure that your kidneys are able to make urine. You want to make sure that there's proper fusion. So a lot of that fluids kind of goes along with it. Same thing with like a rhabdomyolysis. So when someone has rhabdo, they have a whole bunch of CK, like a lot of creatinine kinase in the blood. So an intervention that they do is they give them a ton of fluids, flush out those extra proteins, keep the kidneys healthy and working. Because again, those proteins hurt the kidneys. So kind of goes along with that. And some of the other conditions that we talked about where it leads to an abundance of things, um, like hypercalcemia and we didn't really talk about this one, but um, hyperuricemia, like uric acid, you can flush them all out by going for like a very heavy, aggressive, high IV fluid regimen. Yeah, so if you are gonna have issues with your kidneys, the contrast agents are really bad. I'm not sure if he's talked about it yet because he loves this. He like genuinely loves this. Um, has he talked about something that you can do for something that you can give the patient that's kidney protective? Has he mentioned that yet? He loves this. He really likes. He mentions it like every other lecture, I swear. If he hasn't yet, he probably will eventually. He hasn't mentioned it yet, I'm thinking. Does anyone remember the medication that can be used as an antidote for Tylenol overdose? So that's yeah, so acetylcysteine, that's also known as mucomist. So mucomist is useful for Tylenol overdose, and it also has kind of like a kidney protective effect. So when someone has issues with kidney function but needs to have a contrast, they will give mucomist as a way to help to protect the kidney function and allow them. Oh, okay, yeah, cool. Yeah, he loves it. Yeah, he's even talking about it in clinical. Yeah, I knew it. Yeah, he loves it though. Granted, though, I know his lectures are really old. Uh, like I think they're like 8 or 9 years old. No, no, like genuine. It's kind of funny. I'm not hating on Jin. Yeah, but yeah, he does love that. Say it often. He's cool. I do like him. I do like him quite a lot. He, I don't know if I think I told you, Ryan. I told him what, I think I told you that I sent him the message. I told him that I ate and he didn't reply. I think I told you that. I think I told like the group you and like Nydia, I think was there. So he ended up replying. He replied to me now, like in person. He told me he asked his daughter, and then and then she said his daughter said they left no crumbs. Like, yes. We were talking about lingo. That was so funny. I'll tell you guys something else he said. In on Thursday it was really funny. Remind me to remind you. It's so, like genuinely, it was so funny. I'm not gonna do it on the recording, but I will do it. I will do it after. Sorry. Let me get back. Where we were. So another manifestation you can have is pancytopenia. So basically the same idea, that the overcrowding of the proteins leads to less room for healthy red blood cells, less room for healthy white blood cells and platelets. And you can kind of again pancytopenia associate that with cancer a lot of the time. Uh, some other manifestations. So I guess I should say plasma plasma. But very specifically with this is that this is actually in the bone marrow, so the origin is the bone marrow. But I'm getting a little bit off track. So I missed a few things I wanted to talk about here. It's just like the origins in the bone marrow, which is why it makes kind of sense that we have, again, cancer of the bone marrow. So maybe we'll have some pain. The patients can come in with pathological fractures. Oh yeah, by the way, oh, actually, never mind. I'll say it after. I'm about to say something completely off track, so do that. So pancytopenia, again, we already talked about everything with anemia. We talked about everything with thrombocytopenia. We talked about everything with leukocytopenia. Well, again, it actually has a lot of similar stuff. It's just the thing here that's really important is the excessive protein production. Um, Obviously, you're going to have assess for infection because that's the thing that's going to happen. And because we have this bone pain as well, and we have this crowding, it can also cause hypercalcemia. So cancer is hypercalcemia. Yes. No. It's different from I believe it's different from the M proteins. The Benz-Jones proteins, you'll find them in the urine. So, and this M protein, I think you'll find them in the blood. I'll double check up on that. Actually, I was actually looking back at my reference and I noticed that and I was thinking, yeah. So they are different. So they are different. Yeah. So, like I said, the M protein is in the blood and the Benz Jones is in the UA. So I'll mention that. Yes, exactly. So the Benz Jones is in the urinalysis. Hypercalcemia. So M protein in the blood. So maybe I'll write that in. And then you have Benz Jones in the Jones. Urinalysis will show that. And again, with this, you have kidney damage, kidney renal dysfunction. That's your alongside the pancreas. And we already talked about hypercalcemia a little bit, some of the signs and symptoms that you can see, a lot of muscle weakness, risk of arrhythmias, nausea, vomiting. The hypercalcemia comes from that muscle breakdown. So again, the same patho behind the hypercalcemia here as with the leukemias and lymphomas, where you'll have the breakdown of the bone, leading to the calcium lingering in the blood. Serum protein. You can also have alongside all of this, you can have hyper. I guess that kind of will kind of go. So with the renal dysfunction, what are some things that you can expect with your kidneys being messed up? Yeah, so elevated BUN. And why do you have an elevated BUN? So B, yeah, that's another thing. That would be the Pence Jones and probably just other general proteins in there. Um, well, I guess I guess you don't need to know the full patho. I think it helps. Yeah, we talked about amino acids break down into ammonia, and then ammonia gets broken down by the liver into urea nitrogen, and then your kidneys concentrate that urea nitrogen into the urine, the urinate. But if your kidneys aren't making urine, then your BUN's not being excreted, so it stays in the blood. And that can also lead to it can also lead to confusion and stuff. Your creatinine is basically a waste product that your body has zero purpose for, and your kidneys get rid of through the urine. So if your kidneys aren't making urine, that goes up as well. So all of these things. And again, you will go over, you will have your renal chapter. You will learn a lot more about it. Talked about this, and yeah, exactly. Yeah, it's a waste product that your kidneys have no, like your body has zero use for. So it's immediately that your body gets rid of it as much as it can. What else does your kidney regulate that can be important? So in clinical, you go to clinical and you look at some of your lab values. What's a lab value that's probably always, imagine it's like one of like, it's gotta be at least top five, like something that you look at no matter what, like no matter the condition, you're always looking at it. I know that's vague, but it relates to kidney, so that can help you
We talked about BUN and creatinine already. GFR, sure. Like decrease GFR. What else? That's not related to those. What else is something that your kidney manages that is very important and you probably yeah, okay. Let's break yeah, so now we're ready reaching into electrolytes. What else? Well, yes, potassium. So if you guys remember all the way back in 220, um, you in your shock lecture, you guys go over, your body starts to shunt blood away from your major organs. It does go towards some does go to the kidneys, but your kidneys need such a high amount of blood that it still ends up impacting it anyway. So something that you can have an early stage of like a hypovolemic hemorrhagic shock is hyperkalemia, just because your kidney function is impaired. And in general, when you have impaired kidney functions, so someone with a chronic kidney disease will have hyperkalemia. That's something that you can expect to have. If someone has really, really messed up kidney functions, you'll also will see, just like Michelle mentioned, your sodium can also be impacted. What do you guys think? It's goes up or down? I guess you guys don't know that yet, so I don't know why I'm asking. But actually, some of you might. Maybe someone does. I'm curious. Not just not really emphasized, so you probably don't have to know. How'd you get 42 live? Yeah, it goes down. So you have like dilutional hyponatremia. Yeah, and you guys will get good with you'll get good with the with all that stuff when the kidney chapter gets down. Yeah, there's a lot of stuff your kidneys do. Another thing is that you might have hyperuricemia, which makes sense because we talked about the BUN. So you'll have increased uric acid in the blood. Well, how did that get there? That's basically your BUN, urea nitrogen. Yeah, I think it's deionizes into uric acid. So you have hyperuricemia. Do you guys know? So then going back here to the LIT images being posted. Oh, yeah, those are good resources. So we talk about flushing things out with fluids. What's something that can help with hyperuricemia, like a med? Yeah. What's a medication that can be given for someone with a high amount of uric acid in their blood? Used as a treatment for gout as well. Who knows the answer to that? Yeah, it was you learned this way back in the good old days. Well, actually, probably not, like Vietnam flashback. Right? Okay, I don't recognize that. Let me see if that's a brand name. I'm not good with the brand name, sorry. I guess that is a different got one. I was looking for oh, they gave it to your dad. Oh, cool. Well, not cool, I guess. But I was thinking of allopurinol. I think that's the one that the ones that that's the one that gets mentioned a lot in class. But more likely they'll bring this one up for like a allopurinol. And then for hypercalcemia, um, Ryan, I believe, mentioned already the bisphosphonate, so that's good. You guys are on top of this stuff. You guys know your meds really well, see. So Meta, I believe that's the brand name that they give you guys. Bisphosphonate, yeah. You already mentioned the fluids. You can do chemo to reduce size of the tumor, analgesics for pain. We mentioned it has bone pain, so analgesics help. Now, we talked about contrast is contraindicated. Probably a major thing here. Think about. We did talk about that it is possible to try the mucomist, but I guess they don't really do it in life anymore as often. I think that's everything. I think again the main focus with this one would be the proteins. I think the kidneys and maybe the pancytopenia is always worth thinking about. This one, if it comes up on a question, getting exposed to the word Benz Jones help. And just understanding that a lot of this stuff can be flushed out with the kidneys and making sure to get proper fluids and stuff. And then leukemia, lymphoma, a lot of it is focused on your interventions and understanding some of the signs and symptoms. Pancytopenia is big. Understanding the concept of that is good. Is there any questions on anything we've gone over with this? I believe I gave you guys a date for when we are gonna do the prioritization. Obviously, it can't be for your guys' lecture. I think your lecture hasn't happened yet. How was the midterm exam? Did you see much happening? Good question. I don't recall. I think there must have been at least 5. Mr. Robbins likes to use Kaplan. Yeah, 11.5. Yeah, 11.5. Yeah, yeah. Midterm. I'm trying to remember how that midterm went.
It was the first exam.
First exam? Okay. How many tests do you guys have again? Do you have, I think you have midterm, I think you have a cardiac test, right? Okay. Uh, I'll answer after I guess I'll end the recording. But yeah, any questions? Did I give you guys the questions already? I did.
We're